Good morning. I am so excited to moderate this panel. We have got a great lineup of industry pioneers who are going to offer very different perspectives. But first, I want to comment on the title, Age of Genomics. I was asked to moderate this panel after the idea had already been conceived. So I kind of love the idea that this is not something that is on the horizon. It means we are in it now. So before I introduce the panelists, I want to tell you a little bit about myself and how we've structured our panel. We wanted to take a few minutes to tell you about the work that each person is doing. So everyone's going to present for 3 minutes and even offer some slides, and then we're going to go over individual questions. A little bit about me. I'm a health and science journalist who's been covering genomics for more the social impact of genomics for the past couple of years. I've written about various aspects for Wired magazine, The Washington Post, Time, Atlantic, and I've watched the narrative of genomics change pretty significantly in just a few years. I've had many editors who were skeptical about direct-to-consumer companies, thinking they were trying to sell us a bill of goods. There were so many concerns about privacy, or that people would be traumatized about what they would find. Some editors even asked me, like, how do we know it works? One of my favorite examples is NBC News did this segment with 3 triplets. They had 3 blonde female triplets, and they had them each take a test to see if they were related. And then they had it on the review. They had them take the test. They gave back the results, and they did this big reveal on camera to see if the science behind it worked. And so they opened their little cart results on camera, and they're like, yeah, we're related. So I mean, even like that level of skepticism a couple of years ago, and where we are now is pretty telling in my opinion. So today there's more of a recognition that genomics is behind nearly every major advancement for healthcare that will transform our lives, from diagnosing rare diseases to cancer to prenatal health to polygenic risk scores for heart disease, PTSD, and even what drugs you should take. The list, and we don't have time to go over everything, is truly staggering. I'm even getting PR emails promoting a genomics cookbook. Yet there are still huge challenges, as we all know. People are still worried about privacy. It's a huge issue. Some critics say that the consumer market is softening, and there are critical labor shortages for geneticists and genetic counselors. We've also heard in other panels about doctors, their resistance to change their old ways and their old standard of care and incorporate genomics into the clinic. And we only know 1% of what the genome means. And then here's the big one. A survey released on April 25th, DNA Day, found that 54% of people are unfamiliar with the term genomics, and that 38% do not know what their genome is. So there's still a lot of work to be done in terms of education, in terms of bringing it into the clinic. So on that note, I'm proud to introduce the people on the front lines who are doing it. We've got Rodrigo Martinez. He's the Chief Marketing and Design Officer for Veritas Genetics. Rodrigo lives at the crossroads of biology plus technology plus design. He is Chief Marketing and Design Officer at Veritas Genetics. Oh, I said it again. Previously, Rodrigo is Life Sciences Chief Strategist at IDEO, a principal of the Boston Consulting Group. We also have Lisa Alderson. She is the co-founder and CEO of Genome Medical, a leading telegenomics technology and services company that is dedicated to bringing genomics to everyday care. And finally, Pariah Baim, founder and CEO of Cellmatics. She founded Cellmatics in 2009 to empower women to be more proactive and informed about their fertility through better data, including genomics. So, Rodrigo, do you want to go ahead and start for us?
I think Lisa's going to go first.
Okay.
Thank you, Sarah. It's fantastic to be here. We're excited to talk a little bit more about genetics and genomics today. and in particular, how genomics is being used and integrated into clinical care is an area that I'll focus on and spend a few minutes before we get started. So we really use genomics to both inform prevention, meaning understand our risk for disease. We use genomics to get to a faster diagnosis and a more informed diagnosis, and then we use genomics really to guide our treatment decisions. And ultimately, genomics is, in my eyes, one of the most exciting advancements in healthcare in our lifetime. It really is a driver towards precision medicine and value-based care. One of the biggest challenges we see is how do we integrate genetics and genomics into clinical care at the point of care? And there are really considerable challenges in the market today. First, there is this knowledge gap and a care gap. It's actually less than about 1 in 5 individuals who would meet NCCN guidelines for genetic testing today are actually getting that testing. And that's where we have reimbursement coverage, medical management guidelines already in place. We also have a global shortage of genetic specialists. In the United States, where you see these purple dots, that's really where most of the geneticists and genetic counselors are concentrated. They're at leading academic centers, and yet about 80% of the patient population is seen more in the community. So we don't have sufficient access to expertise today for current medical needs, let alone what's coming in our genomics technology revolution. My viewpoint is that we really need education, we need clinical support, and we need increased access to these genetic specialists to help support the integration of genomic information into clinical care today. I founded Genome Medical to do just that and to really bridge the care gap present that I see across the United States. I've been touched by genetics and genomics in my own family and have had many friends and family members affected. And now that we have the medicine, the science, and the technology, I'm just passionate about building the opportunity for every patient in every zip code to have access. Just to briefly talk a little bit about Genome Medical, we really are focused on 2 areas. The first is building the world's largest network of clinical genomics expertise and to make those experts more available through multiple modalities, both to patients and to providers. Our second area of focus is in building the digital infrastructure to innovate on care delivery so we can make genetic-based care much more accessible. Just this morning, we announced Genome Care Delivery, a technology platform that increases access and affordability. Our clinicians see patients in all 50 states via virtual care, and we support patients in 6 different specialty areas. We offer next-day appointments. And through this technology platform, we really provide guidance, first around education, then assessment, to be able to identify the individuals that are at most elevated risk and to take them on a specialty care pathway that enables increased access. We then select the right test, we order that test for the patient, and we then integrate results into ongoing clinical care for the individual. Ultimately, genomics is about your lifelong journey. We can glean different insights from our genome at different life milestones. And part of what we're all here today is to really help focus on what that journey can look like with the advancements in medicine that we're all bringing forward. Thank you.
We don't know who's next.
Waiting to see which slide pops up.
Whoever's controlling the slides, could you pass to the next presentation, please?
They're on it.
I think.
There we go.
Okay, good.
That awkward silence. It's fine. All right. So I'm going to take 3 minutes to go a little bit in a bigger picture. So I think the question first is, where are we in consumer genomics? And we're sort of here. So we're at this critical inflection point in a series of things that are happening in this particular space. And I want to share with you some dimensions about that are happening, and then we'll see what might this look like going forward. So one is, there is some indication that the fad of ancestry is somewhat slowing and plateauing. We know there's a series of regulation changes happening. What can we communicate to consumers, to patients, under what characteristics, et cetera? That is changing as well. There's obviously privacy awareness and the rise, and that has nothing to do just with genomics, but it also has to do in general with our digital lives, politics, et cetera. Clearly, a series of emerging tools to manage, query the data were early on, and yes, most of what we all hear as AI is probably BS, but there's clearly some strong tools that are emerging here, and there's a lot more coming. And then there are three that I want to focus more in detail. So one is clearly the decreasing of cost, of how much it costs to sequence a genome, and I'll take 15 seconds there. Remember, a genome is all of the genetic information in your chromosomes, and that is 6.4 billion letters, not 3.2, to be clear. Sequencing is basically having the sequence of the majority of that data, and the cost of doing that is what we refer in this particular point to this decreasing cost. It has nothing to do with you, the price of a consumer paying to get access to that. This is just the decreasing sequencing cost. The technology is shifting from genotyping to sequencing. So most of the genomics tests that we all know, like 23andMe or Ancestry or others, use a technology called genotyping. They basically look at a very small part of the genome, less than 1%, and they make some calls of what is there, and is it a yes, is it a no, is it a yes, is it a no. It's very different from sequencing, which is actually sequencing the majority of the genome, sequence letter to letter to letter to letter. And that's a clear difference. And then, of course, the value of why would I want to know information in my genome, that the value of, and our understanding of that value is increasing. But this is not new in a way. This is the first slide that was created to show that the accumulation of DNA data was so much faster than Moore's law. This is a slide that Juan Enriquez and I did actually back in 2001. So we could see that this was coming. Now, you've seen a version of the slide, which is the cost of sequencing. And we went from 3 billion in the first human genome, down, 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 down over the years, right? And there is something around the $1,000 benchmark. And we launched the first test for consumers and physicians of $1,000 for a whole genome. And it was a deal, it was a big deal. And there was actually a book that came out in 2010. This is Kevin Davis' book called The 1,000 Genome. And the point was like, that will shift a series of possibilities, and that will happen in 15 or 20 years later. And that happened 5 years later. Now, but this only gives us one variable. What we really need to see is how does consumer adoption increase as this price goes down? And this has basically triggered the era of reading genomes, the read-only era. We basically read and try to understand. Now, we've now, in a way, entered the second phase, which is read and write. Right? We all heard about CRISPR and editing, and we're early on, but now we've sort of entered the read and write era. And there's a series of companies that are moving as this evolution happens. And here I just have an example of a few of them. So this axis has where most of the value is entertainment, or most of the value is like clinical, medical. And again, this is not, I'm not trying to make only one point, but just to give you a landscape. And there's genotyping, the technology that I mentioned, and then there's sequencing. And we know that 23andMe has created a very good platform, customer base, Ancestry as well. And they are on the genotyping side with most of what they offer entertainment. And then there's their interest to move into more medical and clinical value. Ancestry is moving now, trying to move onto the space of sequencing. They made some announcement recently. Other companies are moving more into population health. We have sort of started up in the higher price, more medical clinical value area, and this is changing. So finally, just to wrap up, we're basically entering now an era that we call the social genome era. And this is probably the next 5, 10, 20, 25 years. That doesn't matter. The point is that increasingly, many aspects of our life are going to be determined, serviced, supported by not just our genome, but other biological data, clearly through companies like Lisa's, and we'll talk about PRI. So I'll wrap with this to kick it off. Probably in the next 5 to 10 years, every newborn will be sequenced. The sequence will be practically free. Today is $600. interpretation, understanding what is in the genome is probably the key differentiator. New products and services such as what we're going to discuss today, and then eventually we'll have clearly more of an integration with other omics, all with its pros and cons and limitations that we should also discuss.
Guess I'll stand too. Thanks. Okay, thank you. So I started my career on the front lines of precision medicine and oncology. And I was focused on women's gynecological cancers. And it was a pretty exciting time to be a biologist. So as Lisa and Rodrigo mentioned, genomic technologies were really taking off. But one of the things that I realized as my career shifted from focusing on women's gynecological cancers to women's reproductive health is that it felt like I was, from a technological standpoint, taking a step decades back. And one of the big drivers of that has been funding disparities. And I founded Cellmatics in 2009 because I saw an opportunity to leverage some of these very exciting genomic technologies, the plummeting cost of genetic technologies, to really disrupt women's health. So even though there are huge funding disparities, these are conditions that impact reproductive conditions like endometriosis and polycystic ovary syndrome impact over 30% of women around the world. And one of the main tools that we have in our armamentarium to treat and manage these conditions is hormonal birth control. And that drug was developed in the middle of the last century and really has not progressed much since then. And what we've learned is that many women can't leverage this drug because of side effects. And we've also learned that women who take these drugs for decades end up with health consequences later in life. One of the things that I find the most baffling about why we put such little focus on doing R&D in this space is that we know that a woman's reproductive health underlies really every aspect of her health, and I'll talk about that in a minute. But that explains why we have such a high side effect profile with these hormonal interventions. So funding disparities translate into data disparities. And what our focus at Cellmatics has been over the last decade is building a disease-specific atlas, we call it the reproductive atlas, to really start to address these gaps so that we can create the underlying data sets to help bring greater insight to women who are navigating reproductive health decisions. Reproductive Atlas is, it's really a centralized repository of multi-omics data, but also we've had to develop tools to help us structure and harmonize data sets from the public domain, so the biomedical literature, et cetera. We've in-licensed large data sets like the Women's Health Initiative and started harmonizing and pulling data insights and doing discovery work on those large data sets as well. And then by having that bird's eye and understanding where those data are, we've also been funding and progressing together with 15 of the top reproductive health centers in the United States, a number of new cohort studies that are really bringing deep phenotype information on reproductive health to the genetic data that we're also creating, which is important because women's reproductive health is not well annotated in a lot of the large cohorts like the UK Biobank, et cetera. And so one of the advantages of a system like Reproductive Atlas is that you can really get more leverage on data if you can harmonize it, bring it together. And so by bringing all this data together and structuring it in this way, we've been able to power a number of applications over the last several years. So we started off in digital health, building analytics tools. So we built a clinical decision support tool to help counsel patients at reproductive health centers. Next, we launched My Fertility Compass as a consumer-facing light version of that to help women better understand their chances of conceiving, powered by this data. And then more recently, we launched the first multi-gene panel test for risk of reproductive conditions, which we'll talk a little bit about later, called the Fertilome test, to bring subclinical insights into that clinical counseling. And it's really been inspirational to see how having access to this information that women didn't have access to in the clinical setting before has really been changing lives and impacting the creativity that physicians are able to now bring to how they practice medicine for women who are struggling to conceive.
So cool.
But ultimately, the insights that you give a woman are only as powerful as the number of tools that she has to be able to do something with that insight. And so we were excited to also start to leverage these data in Reproductive Atlas to really power the next generation of therapeutics in the space. So in December, we launched our Cellmatics Biosciences division. And we were also excited to have initial support from the Gates Foundation. to start to explore whether these data could help us open up novel mechanisms of action and really move out of the era of hormonal interventions for things like contraceptives. And similar paradigms can be applied throughout reproductive conditions. Many people equate women's health with hormones. And so I get asked a lot, well, how does that work? How are you not going to use hormones to regulate reproductive conditions or to achieve contraception? And the answer is that the playbook is there. We're not writing anything new. As many of you know, this is exactly the direction that other fields of medicine have been going in since we started being able to leverage genomic data sets, which is that if you can leverage humans as the model system and really understand what is disrupted in people who are affected by these conditions and start to build a map of the molecular pathways and the biological processes that underlie health, but also different conditions, then you're sitting on top of novel mechanisms of action, novel drug targets. And so there's nothing novel about that. What's novel is that this playbook has not been run for women's health. And we're excited to have also recently announced a partnership with Evotech in Germany to start to really build out a next generation of drugs to address these unmet needs. And the final point that I'll make is that when you can take these conditions that are quite syndromic, most of them like polycystic ovary syndrome, endometriosis, these are heterogeneous kind of conditions where you get a headline, but it doesn't really tell you a lot about the etiology or what's really driving it. When you can move out of these syndromic descriptors of what's going on and really understand what's going on and what is disrupted with a woman's physiology on a molecular level, then what it allows you to do is understand that many of these conditions are a canary in the coal mine. So for many women, the first diagnosis they'll ever get in their life is a reproductive condition. And what we're learning is that a woman experiencing menstrual pain, irregular periods, maybe trouble conceiving or early menopause, that's really the earliest signal that we're getting that there's some deeper disrupted physiology for that woman and that she's on the path to eventually developing diabetes, obesity, cancer, cardiovascular disease later in life. So we also are very excited, even for people who maybe see women's health as not something that they're focused on, the impact that really moving these things forward and being able to more proactively intervene early in a woman's life can set them up for lifelong health. Thank you.
Thank you. Awesome. So Rodrigo, is there a concern that we've exhausted the wave of early adopters? That's that group that were super interested in finding out every little thing they could about their health, even the really results that could be scary. And how do we engage a new group, who may just not be that interested or think, well, I eat well, I exercise, I'm doing everything I can anyway, so what's the point of getting more detailed information?
Yeah, I mean, I think clearly the interest over the last decade was partly fueled by the idea of the whole ancestry space. And then there's some other aspects that have come with wellness, health. Clearly, this interest is plateauing, but it's also shifting. So, over 68% of the customers that Veritas has already have 23andMe. So there's an interest to learn more. Okay, I've learned certain things that are interesting or funny or good to know or something or ancestry that I really cared about. Now I know that there's a lot more that can happen that is useful, that could actually be very beneficial to my health. So I think that interest is shifting. Definitely there's still many of us that think, well, do I really want to know? And that's also shifting, right? You don't stop going to the dentist for the fear that you might have a cavity. You go to the dentist to prevent having problems with your health. And that mindset, that shift in mindset is starting to happen where people start to see, actually, yeah, I could learn something useful, not just for me, but for my family and for my kids. So I think we'll see more of that shift happening. We have way, way, way long to go for sure.
Awesome. Lisa, what role do you think genetic counselors will play in making genomics more mainstream and giving doctors more receptive to bringing it into the clinic? Would they feel more confident, talking about it if they knew they could refer their patients to a really competent genetic counselor?
So genetics and genomics really touches all areas of medicine. And so one of the challenges of trying to integrate it into clinical care is that it means virtually every oncologist, every cardiologist, every neurologist, every pediatrician, every primary care physician, ultimately needs to elevate their knowledge in genetics and genomics. And most physicians at the time they went to med school maybe had a semester, and that might have been 15 years ago. And so part of what's happened is the field is progressing so rapidly that even the experts, even the geneticists and the genetic counselors, human biology is complex, and there's over 7,000 Mendelian inherited disorders. And so I think of it just like any other specialty area of medicine. Ultimately, you want your primary care physician to be able to help identify that risk and provide access to genetics. And so really the role for geneticists and genetic counselors that I see is it's not about seeing all the patients, it's about seeing the patients with the highest need and the highest complexity and really giving tools to other providers to ultimately integrate this into clinical care. And that's gonna take a whole generation ultimately, just because it is sort of an advancement in how we deliver healthcare.
Awesome. Pariah, I want to ask you sort of a shade of the same question. What are the challenges of getting it into the clinic and having doctors incorporate it? In some ways, I feel like this mirrors the cancer experience. You've got doctors who follow a standard of care, especially for something like reproductive technology. They give you a very specific hormonal stimulation protocol, and they may not tinker with it unless you don't respond well to the first one. So, and I feel like with fertility treatment, there's so much money and emotions on the line. Like, how do we make this shift?
Yeah, so one of the things that sticks out in my memory that really resonated while Lisa was speaking is when we first introduced the Fertilome test into the marketplace for reproductive endocrinologists to use with women who were going through infertility treatment, the feedback that we got from physicians was, this is a completely new language. And so we realized, I think our focus was on trying to build and validate and commercialize this test. And what we learned when we actually went out to the marketplace is we were becoming educators. We really had to start with the fundamentals, even in trying to create kind of 101 genomics, genetics, educational modules. So I do think that it's a challenge. And I think it's going to be a challenge for anyone like us and others who are building the first test to really bring precision personalized medicine to a new field. Don't underestimate how much work it's going to be just to deal with the fundamentals.
And feel free to tell us what are some of the genetic insights like that test could tell you.
Yeah, so it was something that really we had a point of view when we took it into the clinic, and it was interesting to see how in some ways those hypotheses were validated, but how new interesting ways that the test could be leveraged it really was a collaborative process between the provider and the scientists who were bringing this test forward. So actionability is really, in something like reproductive health, it depends when you have access to this information. So if you have access to, for example, a genetic marker that predisposes you to have premature menopause, if you have that insight earlier in your life, the action you can take is to be more proactive about protecting your health and your ovarian health, potentially preserving your fertility through egg freezing, having children younger, getting to a specialist sooner. But what we found is that also for women who it was already, let's say, too late, maybe they had premature menopause and the physician was running the test more just as part of the diagnostic odyssey that they were on to try to understand why this had happened to them, was that there was utility in the test that if a woman tested positive for a marker, we were hearing feedback from the physicians that they were seeing very emotional responses on the part of women saying, so it wasn't my fault. So it means that potentially this is something that I inherited. I've talked to other women in my family, the stories are coming out now that they struggled. We found that reproductive health, because it's often stigmatized, women often didn't even know they had a family history of these things until they tested positive for these markers.
That's incredible, because so much of these assessments, it's all guesswork or based on, a general age and not people's individualized history. So, that's a really big shift in fertility medicine. So that's exciting. Rodrigo, I talked to Illumina CEO Francis D'Souza earlier in this conference, and we talked about your genomic record your genomic information being part of your permanent medical record, let's say in 5 years. You talked about sequencing babies at birth. Give us some really interesting examples of how you see this information playing a role throughout your life. Like, how would it inform your health? Like, when would you access it? What would it tell you and when?
Yeah. So in case it's not clear, because sometimes we do get this question, which is, do you compete with Illumina? Not at all. We're actually very good collaborators. We use their machines to sequence your genome. So we're their customer of machines and equipment, et cetera, to do that, right? So I think the ability to have a whole genome sequence, what you get is actually a report, right? Some people want the data, but what they really want is the insights. What does this mean? What am I at risk for? So we have a report that distinguishes, these are red, clinically relevant things you need to talk to your doctor about this week because you might drop dead. And that's 3 to 5% of people. Just think about it. Then 90% of people learn some risks that are inherent, have an aspect of it that have been inherited, but that really have to do with their lifestyle. So you can actually act upon on many of those risks to change, if you like, whether you get a disease or not. I'll give you a very specific example. I have a predisposition for pulmonary fibrosis, which means that there's a chance, whatever that percentage is, that when I'm in my 60s or 70s, I get fibroids in my lungs. The things that cause it are exposure to dust of metal, wood, and stone. So I don't go to construction sites. I basically, if there's a construction site on the street, I just go to the other side, right? That's all I need to do to change my lifestyle, and that might actually be a factor that avoids this disease for me. And everybody has dozens of these aspects, right? So I think that there's that. Now, to your question about where do we go through lifetime, I think what you're going to see is we're in this transition period where we're sequencing my daughter. I have 2 daughters. One is 12, one is 1. The one that is 1, we're going to sequence her soon. What I want that information is to inform her childhood years for anything we need to keep an eye for. Then I want to make sure I have the support of clinical genetics, genetic counselors, and other important clinical support through companies like Lisa's, so that along the way we can have all the support that we need to understand how the risks evolve, what happened, et cetera. At some point, she might have some questions about fertility. She already has her genome sequenced. She might go to Cellmatics and say, hey, can you look in there or do some additional tests, but we already know this. So what we want is everybody to have this resource that you can act upon through life, first as a preventive measure, then if you need it for a particular situation, whether it's health related in any of the aspects that we know. And of course, if you get sick, if you get a really bad condition, you want to find out everything, right? Like we have people that will send us their grades from elementary school once they get sick. So you can also go now deeper into this genome as in a diagnostic form and try to understand what might there be some causes there. So we really see this personal baseline will accompany you through your life.
Nice. Lisa, during our prep call, you talked about using a strategy of getting employers on board to make genetic counseling a benefit, and that would be a good way of increasing awareness and adoption and just generating excitement that it's a cool thing to have in your life. Tell us about that.
Yeah, so one of the areas we do work with are employer organizations, often self-insured, but not always. And it's really about building those bridges around education and awareness. So anybody who has had a history of cancer in their family, particularly if you have anybody who is diagnosed at an early age, under most commercial insurance plans, you would be eligible for insurance-covered genetic testing. And often those individuals are missed. Same for cardiovascular disease. A friend of mine from business school was running the Boston Marathon at age 27 and died of a sudden cardiac arrest. That is tragic. This is a preventable condition if we have the knowledge and the insights to take action sooner. If there's anybody in the family with a sudden cardiac event such as that, you need genetics. And so there are all of these critical stages today, and the vast majority of the population just is not aware, even what is a hereditary condition, what would make one eligible for coverage. And so we see the market in really 2 areas. One is, how do we bridge this gap where there's such clear clinical need today and patients are just not getting picked up? And so with employers, that's one of our avenues, because we can bring the education and the awareness and the assessment tools forward and find those individuals. I think of it a little bit like employers might have flu shots available on site, right? It's not that you couldn't get it elsewhere, but it adds convenience. In the case of genetics and genomics, that problem is magnified because often you can't get it elsewhere unless it's a long drive or a long wait. We hear stories of patients waiting weeks, months, even a year to see a pediatric geneticist. And so it's really about bridging those care models for increased easier access.
Awesome. Puraya, let's see. Oh yeah, how do you see genomics changing the stigma of infertility? There's been an awesome movement in the last couple of years in terms of increasing awareness and talking about the stigma. People are more open about it, yet there's still a lot of women and men have a lot of shame about the issue. They talk about having bad eggs or sperm, but it would be awesome to have this reframed as just a genetic insight, that it's not you, it's your genes. Do you want to talk a little bit about that shift and how genomics can facilitate that?
Sure. So for people in the audience who've gone through their fertility journey already, have started their own families, you know that as soon as you tell anybody that you're starting a family, you get unsolicited advice from anybody about everything. And so this is really amplified for people who are struggling because everybody has an acupuncturist or a trip to Hawaii or their neighbor who tried whatever. And what we're trying to do is give women tools to be able to say to their mother-in-law, for example, we tried Hawaii, but it turns out I have an alteration in my androgen receptor that disrupts estrogen signaling during the implantation window. And we want to give them tools to really make that more data-driven. And it really comes back to that guilt piece. One of the biggest burdens, we say in the reproductive health field, that people often run out of their emotional credit card before they run out of their actual credit card or their employee benefits. And so what we're trying to do is by helping them understand that this was not their fault, that maybe they were wired this way, that it just at least takes some of that emotional burden off, and it puts them more into that troubleshooting mindset of like, okay, so I have this disrupted estrogen signaling in my uterus. What can we do about it?
Nice. Rodrigo, how would you like to see public perception change? At one hand, we've got the ability of the genome to tell us really significant, serious information. At the same time, I'm getting emails from 23andMe saying, we found if you have the gene, if you like cilantro. So how do you reconcile both things? And then you go on and it says that I may or may not like cilantro, but I really like it, so I really don't know what to do with this information. I mean, at the same time, there's a lot of interest in, the ancestry part. So we've got this fun, curious, lightheartedness about it, but at the same time, we've got very serious implications. So what do we do with all that?
Yeah, I mean, look, 23andMe, Ancestry, and other companies have done an incredible job to create awareness in consumers of just even what DNA is. Probably more doctors know about genetic tests through 23andMe and Ancestry than any other way, right? So we need to recognize that they opened the market. They decided, because at the time, really the only viable technology was genotyping. They really couldn't do sequencing because it was too expensive, and it was really hard to manage the data, et cetera. But now we're at a point where, as the price of sequencing approaches very closely a price of a 23andMe or an Ancestry set, et cetera, the awareness comes up because, I already know, I've already seen 16 ads for Ancestry or 23andMe or other companies every day on my feed, and now I see one from a company that might offer something that is useful clinically and it's not much more expensive. So there's the shift. Now, you don't have to have either or, right? We in our report, we give all the traits that 23andMe gives and more. They're not as colorful or as organized in the same way. We also give a version of Ancestry that is not connected to any other database, but we're really not emphasizing that. What we're saying is you could have it all. But when you need medical and clinical information, you need to be able to have it. And sure, if you want to have some of the interesting and fun things and conversation starters and some of your Ancestry elements, absolutely. I think you need both. So we're clearly in a transition period. The last point I'll make about how do you get people to be part of this transition period is we're going to need a bunch of celebrities, just like we had in the case of Angelina Jolie with a BRCA1, BRCA2. We are all receptives of everything we see in our social media and media in general, et cetera. So we're going to need, and we have now more interested people that come to us and say, hey, can I do this? Can I talk about this? Sure. So you'll see a shift also in attention and eyeballs as more and more people that we all know have their genome sequenced and explain, this is why I did it, and this is what I learned, and my life has changed.
Nice. And tell us, why is the $600 price point such a big deal in the history of consumer genomics?
Well, I mean, I think the first was the $1,000, right? We launched the $1,000 because there had been all this attention about when we reached that milestone. It was totally arbitrary. Could have been something else. Now, this last July, we dropped the price to $599, clearly as a way to get consumer adoption to increase, and it doubled.
And
right?
of your whole genome, not just this.
We're talking whole genome, clinical grade. This is the highest standard of your genome that you can get, HIPAA compliant, clear cap in the cloud, encrypted, all of that, right? So 600 is, fantastic. We need to go lower. Like, we need to go sooner to $399 to $299, and we really see this in the next couple of years to go closer to the 200 level, and eventually it should be free. It should be more about what can you do with it,
nice,
as opposed to the sequencing.
Well, we're getting the sign to wrap up. Thank you guys so much. It's been a great panel, and thank you everyone for listening to us.
I'm going to take 20 seconds. We got 100 genomes for $399 just for this room. If you're interested, there's one of these in your chairs, and if not, come see me. Only 100 for $399 because we want these people that are interested in the topic to be part of this genomic revolution.
Awesome. Thank you.
Thank you.